Bu kongremizin ikinci günü yıldızlar, dünya çapındaki yıldızlardan bir tanesini daha bugün ağırlayacağız konuşmalarıyla. Dün kısa bir sunumu vardı. Bugün daha geniş olarak konferans şeklinde Kenji Hashimoto'yu takdim etmek istiyorum size. Kendisini zaten çok dünya çapında bir insan biliyorsunuz. 800'den fazla yayını olan birçok dergide editörlük yapan bir insan. Geniş olarak Feyzo Hocam CV'sini aktaracak biraz sonra. Biz en çok bu dirençli depresyon konusundaki çalışmaları, Ketamine, Esketamin ve şimdi bugün anlatacağı Arketaminle ilgili çalışmalarla kendisini biliyoruz. Psikiyatride çok önemli bir yer teşkil ediyor biliyorsunuz depresyon ve dirençli depresyon özellikle neredeyse 1/3 dirençli hastaların ve bu konuda birçok çabaya rağmen henüz tam net sonuçlar elde edilemedi. Birçok yeni gelişmeye işte esketamin vesaire gibi çalışmalara, ilaç çalışmalarına rağmen yan etkiler vesaire dolayısıyla çok yaygın bir şekilde de kullanamıyoruz. Arketamin bu yönden bir ümit vaat eden bir şey. O yüzden özellikle ilginizi çekeceğine inanıyorum. Şimdi Feyzo Hocam'a bırakıyorum. Kendisini, CV'sini takdim etmek üzere.
Teşekkür ederim hocam. Günaydınlar. Professor Kenji Hashimoto received his PhD from Kyushu University in Japan after holding research positions at the National Institute on Drug Abuse in Baltimore, the National Center of Neurobiology and Psychiatry in Tokyo, and the pharmaceutical company in Japan. He joined the Graduate School of Medicine, Shiba University in 2001. Since 2005, he has served as professor at the Center of Forensic Mental Health, Shiba University in Japan. He also holds appointments as a guest professor at the first affiliated hospital in Zenshu University, if I'm pronouncing right, and Southwest Medical University in China. His primary research field is translational psychiatry with a focus on molecular and circuit mechanisms of ketamine and its enantiomers, as well as the endocytogen MDMA. His work also addresses brain-body communication in health and neuropsychiatric disorders. Dr. Hashimoto is an editor of Psychopharmacology and European Archives of Psychiatry and Clinical Neuroscience, and serves on the editorial boards of Molecular Psychiatry, Brain Behavior and Immunity, and several other journals. According to Scopus, he has an H index of 99 and has authored over 800 peer-reviewed publications. Dr. Hashimoto, the floor is yours.
Thank you very much. Nice introduction. I'm very happy to be here. So my name is Kenji Hashimoto from Japan. This is the first visit to Turkey. I'm very happy to be here. So today, my title is Arketamine, the overlooked driver of ketamine rapid and sustained antidepressant. The title is a little aggressive, but maybe you are familiar with the racemic ketamine and esketamine. But my study shows another enantiomer. Arketamine is much better than racemic ketamine and esketamine. So today I will show the brief history why arketamine is much better than esketamine. This is my COI. I have the inventor of the patent of arketamine and S-norketamine. Today I talk about the two compounds for depression. So this slide are medical needs for depression. So depression is the very most common psychiatric disorder in the world. More than 300 million people suffer from depression. This is also depression slide, so marked increase in the prevalence of depression after adjustment for the COVID-19 pandemic. So about 28% increase. This slide is a suicide rate. So this is a WHO report. Data quality of age standardized suicide rate 2019. So more than 200,000 people die due to suicide every year. Suicide is the fourth leading cause of death among young people. Also, about 77% of global suicide occur in lower and middle-income countries. So suicide is a very big problem in mental health. So now we have many antidepressants, such as the SSRI and SNRI, but it takes a couple of weeks or months to achieve the antidepressant efficacy of the current antidepressant, such as the SSRI and SNRI. The onset is very slow. Also, second is 1/3 of depressed patients in treatment resistant. Third, current antidepressants are not effective in the treatment of depression or bipolar disorder. Fourth, the current antidepressants are not effective in the suicide ideation of patients with severe depression. But ketamine can cover all these unmet medical needs. So this is a very important compound for severe depression. So this is a magazine Time, a special issue. Title is The Antidepressant. Depression afflicts 300 million people in the world. 1/3 don't respond to treatment, treatment resistant. A surprising new drug, ketamine, may change that. So a ketamine antidepressant effect is the biggest breakthrough in depression research in the past 60 years. So ketamine has a very important new antidepressant. So also another topic is classical psychedelics and non-hallucinogenic psychoplastogen in psychiatric disorder. Very recently, we published a review article with the chairman, so in the psychiatry and clinical psychopharmacology. Now this paper is published. If you are interested in the classic psychedelic and non-hallucinogenic psychoplastogen, please check this paper. But today I will focus on ketamine. So next we talk about the brief history of ketamine and its enantiomer. Ketamine is a very old drug. So 1964, Professor Edward Domino injected the ketamine into human volunteer. Most subjects described a strange experience like a feeling or floating in outer space and having no feeling in their arm or leg. So he and his wife named the ketamine is a dissociative anesthetic. So now we know that ketamine is a dissociative anesthetic drug. So in psychiatric field, so ketamine induces a schizophrenia-like symptom in human volunteer. So symptom is a positive symptom and a negative symptom and cognitive impairment. So many scientists in the United States use the ketamine for schizophrenia model in human. Ketamine has one asymmetric carbon. Two enantiomers is available, S-ketamine and R-ketamine. S-ketamine is generally considered more potent than R-ketamine, particularly in terms of its anesthetic and analgesic effect. It has approximately 4 times the affinity for the NMDA receptor, which is associated with its stronger effect on pain. Second, S-ketamine is effective in management of acute and chronic pain, particularly neuropathic pain. Its analgesic properties are attributed to NMDA receptor antagonists. Third, the use of S-ketamine can be associated with more pronounced psychotropic side effects, such as dissociation and hallucination, which may limit its use in some patients. So this is published in Anesthesiology. So ketamine produces a potent analgesia combined with psychedelic effect. It has been suggested that these two effects are associated with, and possibly that analgesia is generated by ketamine-induced dissociation. The new data using post-hoc analysis support an association or connectivity between ketamine-induced analgesia and dissociation, indicating a role of NMDA receptor inhibition, because many scientists believe that NMDA receptor inhibition induces dissociative symptoms. So now anesthetic esketamine is available in China. Very huge esketamine paper published from Chinese group. So this is a brief summary. So anesthesia feels ketamine, esketamine is a very suitable anesthesia and analgesia. So mechanism of action, one is the NMDA receptor inhibition, and another is the opioid receptor, mu-type opioid receptor activation, and BDNF and mTOR signaling. Also today, another enantiomer, Arketamine, may be suitable for the psychiatric disorder. Also, side effect, adverse effects, such as psychosis, dissociation, and abuse liability, the esketamine and racemiketamine is higher than Arketamine. So next topics, ketamine as a rapid-acting antidepressant. So this is a first paper reporting the antidepressant effects of ketamine in depressed patients. This paper published in Biological Psychiatry by Yale University. As you can see, ketamine-induced psychotic symptoms very quickly. Then psychotic symptoms disappear. Then depressed symptoms gradually decrease, just only one single injection. This is the first paper showing the rapid-acting and long-lasting antidepressant effect of ketamine in MDD patients. Next, NIMH group published in the study treatment-resistant depression. This paper is a very high citation. As you can see, single injection of ketamine significantly decreases HAM-D score. Then this effect is after 7 days. So one single injection of ketamine produces a rapid-acting and sustained antidepressant effect in TRD patients. Also, side effect is very quickly a decrease. This slide is also another indication, treatment-resistant bipolar depression. Also, this is very similar. So single injection of ketamine significantly decrease, then a recovery. This is also BDI score. So one single injection of ketamine induce rapid-acting, sustained antidepressant effect in bipolar disorder patients. Also, this paper published from the Mount Sinai group. So this study used midazolam as control substance. They compare the ketamine and midazolam. As you can see, ketamine significantly decreased MADRS depression score, as you can see in here. Also, response rate with ketamine group is much better than midazolam group. So this study also, ketamine is much better than midazolam group. So after this paper published, many papers published in several journals. So this is a meta-analysis published in American Journal of Psychiatry. As you can see, odds ratio 1 day after single injection about 10. It's a very high odds ratio. Also, odds ratio is a 7 day after single injection, about 4.6. So this meta-analysis shows that ketamine produced rapid-acting and sustained antidepressant effect in TRD patients. Also, this is a meta-analysis of the ketamine infusion on suicide ideation. This is a meta-analysis. As you can see, single injection of ketamine significantly decreases the suicide ideation score after a 1 day injection. Then effect is a long-lasting 7 days. So now we don't have the medication to reduce the suicide ideation. So ketamine effect on the suicide ideation is a very big efficacy. So this meta-analysis, so ketamine rapidly decreases suicide ideation in patients with severe depression. So ketamine is a very popular drug. So very famous businessman Elon Musk used ketamine for his negative symptoms. So this news published in Nature in 2024. So now in the United States, prescription rate is very high. This slide shows the number of patients with ketamine prescription per 100,000 patients annually. As you can see, off-label ketamine prescription rate in the United States dramatically increased. Also, this slide shows the past year use of psychedelic substance by adults in the United States in last September. As you can see, top is psilocybin. So ketamine also very popular recreational drug. So next, I talk about the Arketamine as a novel antidepressant with safe profile. I will talk about why Arketamine is better. So ketamine has a two enantiomer, esketamine and Arketamine. So this is a binding affinity at NMDA receptor. So tritium MK801 is a very selective and high affinity ligand at NMDA receptor. So as you can see, esketamine is a low 0.3 micromolar high affinity at NMDA receptor. Arketamine is a low affinity at NMDA receptor. So many scientists believe the NMDA receptor play a role in the antidepressant effect of ketamine. So Janssen Pharmaceutical selected the esketamine for new antidepressant. So the next, so 2019, United States and Europe approved the Johnson & Johnson esketamine nasal spray for TRD patients. Now also additionally MDD patients with suicide ideation and suicide thought. Also in China, also is now Spravato is available, but in Japan is not available this esketamine nasal spray. So this is a hypothesis, ketamine or esketamine. It's a very simple hypothesis. This paper from John Crystal and Dennis Chaney is a very famous scientist in United States. They are experts for ketamine research. So they are from the Yale University. So this is a very simple hypothesis. Ketamine or esketamine blocks the NMDA receptor in the GABA terminal. Then release of GABA, then activation on AMPA receptor, finally increased BDNF-traffic signaling. This is very important for the rapid-acting and long-lasting antidepressant effect. This hypothesis is very simple. Many scientists believe this hypothesis. Very simple. NMDA inhibition play a role in the rapid-acting and sustained antidepressant effect of ketamine. So we know many psychiatrists in the United States and other countries believe racemic ketamine has a very excellent antidepressant effect in severe depression. So, but racemic ketamine has several side effect profiles, such as dissociation and abuse potential. So many scientists and several pharmaceutical companies developed the clinical trial of the non-ketamine NMDA receptor antagonist, memantine, traxoprodiol, lapacinel, ranisemine, and milk compound, the AV101. But all compounds did not produce ketamine-like antidepressant effects in depressed patients. Also, very importantly, a medical company conducted a clinical trial of very selective and high affinity as NMDA receptor antagonist MK81 in depressed patients. But this compound did not produce antidepressant effects of patients. So these clinical data suggest NMDA receptor may not play a role in the antidepressant effects of ketamine. This is my hypothesis. More than 10 years ago, I have this hypothesis. So also, another very important clinical data. So this paper published NIMH. So ketamine produces a dissociative symptom and antidepressant effect. So many scientists believe the NMDA receptor block induce dissociation. But in this paper, the literature does not support the conclusion. Dissociation is necessary for antidepressant response to ketamine. So this paper shows no relationship between dissociation and antidepressant effects. Also, this paper published from the Janssen Pharmaceutical, this group analyzed phase 3 data. So y x-axis is the MADRS score, day 2, day 28, day 28, y-axis and dissociation score. As you can see, no correlation. This paper suggests no relationship between dissociation and antidepressant effect of esketamine nasal spray. This is my review article. So many clinical studies have shown that dissociative symptoms following the administration of ketamine or esketamine are not directed to their antidepressant effect. So NMDA receptor inhibition induces dissociative symptoms. So this clinical data shows that NMDA receptor inhibition may not play a major role in the antidepressant effects of esketamine. So so I have an idea. Arketamine more potent than esketamine. This is my hypothesis. More than 10 years ago, I have a hypothesis. But in that time, we don't have the racemic ketamine because racemic ketamine and enantiomer are controlled substance in Japan. So it's very difficult to examine the two enantiomer in animal model. So I purchased a ketamine injection bottle from the company. Then I purified here. So our ketamine can form the salt with the D-tartaric acid. So we can separate the D-ketamine from the racemic ketamine. In addition, we separate the S-ketamine using the L-tartaric acid. So we purify the two enantiomer. Finally, we prepare the ketamine hydrochloride and S-ketamine hydrochloride. Then we use animal study. So this is a very old paper, a small paper. So we examine the effect of the two enantiomer in this model. So as you can see, Arketamine was more potent than esketamine. Then 2015, we use another animal model, a social defeat stress model. In this model, we found that Arketamine was more potent than esketamine. In the same paper, we use another animal model, rat land helpless model. In this model, also we found that Arketamine was more potent than esketamine. So we published two papers showing that Arketamine is much better than esketamine, but nobody believes our Arketamine paper. But next year, 2015, NIH and the University of Maryland group published in paper in Nature. So this paper also Arketamine was more potent than esketamine. So this is the first paper replicating our finding. After this paper published in a famous journal, so some people believe our Arketamine story, but most scientists in the world don't believe our Arketamine. So this paper published in Nature. So Professor Xiaofei Wang and Mingming Luo, Professor Wang is here. So this paper shows new mechanisms. Adenosine signaling play a role in the antidepressant effect of ketamine. Also, this paper reported no correlation between NMDA receptor antagonist and adenosine release, suggests a non-NMDA mechanism mediates the adenosine surge and antidepressant effect. Also, many other papers show the antidepressant effect of ketamine and MK801 are quite different. So these preclinical data shows the NMDA receptor may not play a role in the antidepressant effect of ketamine. So next, we talk about the side effects profile. So ketamine has a very excellent antidepressant, but ketamine has a very severe side effects, psychotomimetic effect, and dissociative symptom, and abuse potential. So this is our paper. So using the carbon lacroprized PET, we measure the dopamine release. As you can see, esketamine significantly decreases the binding potential of dopamine D2/3 receptor, but arketamine did not change. This PET study suggests that dopamine release from synaptic terminal is associated with psychotomimetic effect of esketamine. So this PET study suggests arketamine is safe compared to esketamine. Also, ketamine has abuse liability. So many countries prohibit ketamine. So we examine the rewarding effects of ketamine, esketamine, and arketamine. As you can see, ketamine and esketamine significantly increase the CPP score. This data suggests that esketamine and ketamine have the abuse liability, but ketamine did not increase the CPP score. So ketamine does not have the abuse liability. Also, this paper published NIDA in the United States. This paper used the drug self-administration model for abuse liability. So this paper shows the abuse liability of ketamine in human, and primarily due to the pharmacological effect of esketamine. Also, esketamine has a moderate affinity at mu-type opioid receptor. So same group, NIDA, reported this paper. So opioid receptor antagonist naloxone decreased esketamine self-administration in rats. So this paper shows the abuse liability of esketamine in human is partly mediated by brain mu opioid receptor. So our data and another group data, so our ketamine has a greater and longer antidepressant-like effects than ketamine in animal model of depression. Also, our ketamine does not cause our behavior abnormality in rodents compared to racemic ketamine and esketamine. So we conclude that Arketamine a rapid onset and sustained antidepressant without side effects. We published many review articles. So next, we talk about the clinical data of Arketamine in human, but sample size is very small. This is an open label studies from the Brazil group. Those of the same, the racemic ketamine, 0.5 milligram per kilogram IV infusion. As you can see, one single injection significantly decreases the MADRS score, then effect is long-lasting. So it's very similar to the racemic ketamine. Very importantly, a side effect profile, side effect dissociation is very, very low. Also, same group published the open label study for bipolar depression. This paper also used 0.5 and 1 milligram per kilogram, significantly decreased the MADRS score, but dissociation is very, very low. Also, same group published a placebo-controlled study. So, ketamine is a lower, higher efficacy, but the primary endpoint did not reach the primary endpoint because a sample size is very, very low. But importantly, ketamine is much better in here. But in this study, also dissociation and other adverse events are very, very low. So this is a phase 2 data by perception neuroscience. My patents are licensed out to the perception neuroscience in New York, in United States. So as you can see, a single injection, we use 30 milligram and 60 milligram. So significant, more than 15 MADRS score reduction after one single injection. But very huge placebo effect, so we could not reach to the primary endpoint. So the company, they analyzed the data of US only. As you can see, the 60 milligram is a long-lasting effect, so significantly decrease. So this is, we did not disappoint this data. So also in this study, no significantly different in sedation or dissociation. So Arketamine is a very safe drug for clinical trial. Also, this is a small case report from the Poland group. This is one of the perception neuroscience clinical trial. So this is a orange line, the 6 leaves before Arketamine injection. Blue line, the 6 leaves after 1 year after single injection of Arketamine. 30 milligram, 60 milligram, 30 milligram. As you can see, dramatically decrease 6 leaves. But this is only 3 cases. This is a phase 1 study data by Chinese company, Enfa. So this is a PK profile and a safety profile. So these, the adverse event of Arketamine injection frequency and recovery spontaneously without treatment. Now this company conducted a phase 2 trial for TRD patients. So this is a side effects profile. Racemic ketamine and esketamine can induce side effects profile, dissociative symptom, but as the antidepressant dose, Arketamine is does not produce dissociative symptom. It's a very safe drug. So another pharmaceutical company in China, Sujian Purity Pharmaceutical Company, is ongoing phase 2 clinical trial. This is Arketamine nasal spray. So next, I talk about a comparison of racemic ketamine and esketamine. So Arketamine is not available. So some paper compare the racemic ketamine and esketamine. This is a paper from the Harvard University, McLean Hospital. So this is a retrospective chart review. This is the data. So blue line is the intranasal esketamine. Green line is the intravenous ketamine. As you can see, IV ketamine leads to greater, faster symptom reduction than IN esketamine in patients with severe TRD. IV ketamine shows a significantly improvement after one treatment, while IN esketamine requires at least 2 treatments. So we know pharmacokinetics of the IV and IN quite different, but we could not explain the difference of the PK between the IN and IV. But this paper did not discuss the role of Arketamine. So we published a letter to the editor. So the overlooked role of Arketamine in Turkish language and Chinese language. Maybe you can understand. Also, Roger McIntyre at Toronto University reported the adverse events data. So this is data, so suicide ideation. So as you can see, ketamine is no problem, but esketamine is a little high. So it's very difficult to conclude the reason. But my hypothesis is that Arketamine included in the racemic ketamine may protect against the esketamine-induced suicide ideation. But this is my hypothesis. Also, this is another FAES database. So this study identifies some new clinical variable potential adverse event signals, such as flashback, tachyphylaxis, otoscopy. Well, notably, occurrence of frequency of the suicide ideation and suicide attempt were relatively high. This study suggests the potential adverse reaction and risk of esketamine in clinical application, especially regarding long-term efficacy, addiction risk, and suicide risk. Also, this is a new paper from Japanese group. So this paper found a new signal in homicide ideation, substance use disorder. Also, this paper shows quite gender difference between the gender difference for esketamine nasal spray. So also this paper published in American Journal of Psychiatry, esketamine treatment for depression. So conclusion, esketamine efficacy as an add-on to antidepressant is modest in TRD patient, is absent against suicide itself. But the comment of this paper published in same journal, so this comment contains numerous error, misstatement, and undisclosed methodological limitations that may have contributed to author misleading interpretation with potentially negative implications for patient care. Also, Jero Sanakora of Yale University published American Journal of Psychiatry, Real-World Safety of Esketamine Nasal Spray. Also, Alan Schwartzberg at Stanford University reported the editorial. Then this group's comment in this editorial. Now the safety profile, such as the suicide risk of esketamine nasal spray, remain under debate. So many scientists in the United States have concerns the side effect profiles. Finally, I talk about my hypothesis: S-norketamine, the active metabolite of S-ketamine. So previously, we published the biological psychiatry we examined the ketamine metabolite, S-norketamine and R-norketamine. So as you can see, S-norketamine is a low affinity at NMDA receptor. Binding affinity is very similar to R-ketamine. So we compared the two metabolites in animal model. So as you can see, the S-norketamine has an antidepressant effect, but R-norketamine did not show. So this data suggests that R-ketamine alone shows the antidepressant effect. Not R-norketamine does not produce antidepressant effect. But S-norketamine antidepressant effect is very similar to S-ketamine. Also, this data is also same. So another group published another model. So as you can see, S-norketamine has a low antidepressant effect. Also, another different animal model. So 30 minutes after injection, all metabolites show the weak antidepressant effects. But 7 days after injection, just only S-norketamine has a long-lasting antidepressant effect. So next, we examine the side effect profile. So S-norketamine is a low affinity at NMDA receptor compared to S-ketamine. So psychotic model, hyperlocomotion, preference inhibition, and abuse liability. As you can see, S-ketamine has a side effect profile, but S-norketamine does not have the side effect profile. Also, this is a baseline gamma band change. This is also one of the model of psychosis. So as you can see, S-ketamine does significantly increase, but S-norketamine did not increase. So these side effect profiles, S-norketamine is a very, very safe compared to the parent compounds S-ketamine. So we have the very interesting phenomena chemistry. So Arketamine forms a salt with D-tartaric acid. In contrast, S-ketamine forms salt with L-tartaric acid. Very interestingly, S-norketamine forms a salt with a D-tartaric acid. So chemical properties are not same as pharmacological profile, but these chemical profiles are very important. Maybe Arketamine and S-norketamine may bind to the binding partner, such as specific protein and other target. So we published 2019 is S-norketamine an alternative antidepressant for S-ketamine because S-norketamine is very, very safe. So S-ketamine is a prodrug for S-norketamine for depression, but its adverse events are mediated by S-ketamine. So this is a short summary. So we added the S-norketamine in psychiatry. So, but Arketamine is much better than S-norketamine. So last year I published the ketamine perspective. So in this perspective, many researchers continue to rely on racemic ketamine, even though it two enantiomer shows a distinct pharmacological effect. To fully understand the ketamine complex antidepressant mechanism, each enantiomer must be studied separately. This is very important. So this is summary. Racemic ketamine produces rapid and robust antidepressant action. So esketamine nasal spray is approved for the treatment of TRD and patients with suicidal ideation. So our preclinical study suggests that S-norketamine may serve as safer alternative drug of esketamine. Finally, Arketamine may represent a novel antidepressant with fewer psychotomimetic, dissociative, and abuse-related side effects compared with racemic ketamine and esketamine. But all data is preclinical data and very small human data. So in future, head-to-head randomized trial comparing esketamine with Arketamine and also esketamine with S-norketamine in depression are needed. Thank you very much for your attention.
Çok teşekkür ederiz bu güzel sunumu için. Headphone please. Yeah.
Hi. First of all, thank you for presentation. What is the future of ketamine and esketamine therapy in child and adolescent psychiatry?
Yeah, clinical data is very limited, so maybe a safer drug for Arketamine may be better for adolescents patients with depression, because the safety profile is very important. It's okay.
Başka soru, katkı olan var mı hocam? Yes.
Thanks for a really good talk, Kenji. I really enjoyed it. It was very clear. The whole problem becomes somewhat political because you have the convention that racemic ketamine is okay and people are using S-ketamine, pharma's pushing S-ketamine, and you have this information that is moving against the convention. What do you think it would take to push opinion so that these results could be readily accepted?
Yeah, racemic ketamine is a very popular off-label use in United States and other countries. But racemic ketamine has several side effects profiles and abuse liability. Also, FDA approved the esketamine nasal spray, but some adverse event database suggests that esketamine nasal spray has a suicide ideation risk after repeated use. So, but our data, Arketamine clinical studies are very limited. But my preclinical data suggests Arketamine is much safer. So, long-term use of Arketamine is much better than esketamine. But
yeah, I agree with you.
Yeah.
We talked about this before, and seeing all of the evidence, including other groups, not just your own work.
yeah,
I think you make a very convincing case.
yeah,
But I think it's very important that hopefully a drug company would take this on and do significant clinical trial work
yes, of
with
course.
high enough numbers of
Yeah.
appropriate patients.
Yeah,
Because what you're talking about has very important implications for the future use of
yeah,
ketamine, including sustained effects.
yeah, I agree. So clinical development is very, very important. So now esketamine nasal spray is approved in the world,
Yeah.
but big company, Johnson & Johnson. But now two pharmaceutical companies in China developed the Arketamine. In addition, one or two additional companies in China are very interested in Arketamine. So in the future, if Arketamine can be approved in China, so many Chinese groups conducted a clinical trial comparing the Arketamine vs esketamine in TRD patient and other indications. So maybe it takes a couple of years.
Yeah. Well, that's very encouraging.
Yeah.
The other thing that I found very interesting is your argument that it's not NMDA receptor mechanism.
Yeah.
Because that is also the conventional idea. We were talking, we have colleagues who really believe the NMDA hypothesis, but this is very exciting. So thank you very much. Great
Thank you
talk.
very much. Yeah.
Thank you, Professor Keiji Hashimoto. Very clear presentation, very interesting. Also very important for ketamine to treat the depression and other mental disease in the clinicals. So the question is, most Arketamine is bad than the esketamine or other analog. But most evidence from the preclinical studies.
Yeah.
So we need more evidence from head-to-head clinical trials to approve the Arketamine clinicals. But is there any more evidence about the mechanism? Yeah, these are evidence from the pharmacology and pharmacodynamics. Is there any for the brain circuit, for example, for TrkB receptor, mediate the ketamine, effect on the depression? So do you have any more data, or in your group, other group, there are some of the different Arketamine with others, analog in the signal transduction for BDM for the neurogenesis or neuroplasticity. This is the first issue. Second, you just your mind is very important in the clinical trial. Is there any the Johnson company they developed the RS ketamine in the clinical for supreme for treatment? The Johnson interested in Arketamine, or they want to still keep the dominator in the tradition for ketamine in the depression treatment.
Thank you very much for a nice question. So I agree. Ketamine antidepressant effects mechanism very, very complex. So if NMDA receptor play a role in the antidepressant effect of ketamine, so other NMDA receptor antagonists must show the very similar antidepressant effects in human, but no antidepressant effects. So maybe our data and other group data using the two enantiomer quite different. So now one consensus is BDNF TrkB signaling play a role in the rapid and long-lasting antidepressant effect of Arketamine and esketamine, both. But we don't know what is the primary target of Arketamine and esketamine. This is a very big question. But many ketamine researchers use racemic ketamine in the preclinical study. So we should use two enantiomers separately to determine the molecular mechanism. This is a very important issue. Also, as you know, the clinical study is very, very important. So 2015, my group published the second paper of Arketamine. Then this paper is published. I contacted Johnson & Johnson scientists, but they are not interested in my Arketamine. This is the story.
Thank you so much, Kenji. This wonderful talk. You know, as a pharmacologist, I was always had a doubt about if the story depends on only NMDA receptors, then why memantine and other drugs are not working as an antidepressant. So it seems there are so many questions we have to work on. I'm very sorry because of the next session, we have to wrap up. Thank you so much, and we may continue probably for more questions in coffee break. Thank you.